Came up on. There you go.
All right, we're good now.
Today we have Dr. Chris Reilly. He's coming remotely from us from a different state. He is our adult hematology transplant and TP53 guy that we'd love to talk to. Um, he is at Dana-Farber in Boston. And Dr. Chris, I'll let you take it away. Anybody that gets on, please make sure you mute, and this is being recorded.
Great. Thank you so much for the introduction and the opportunity as well to speak with you this morning. I know just from my prior, work with this group and just being in this field for the last several years, I know how important it is to really communicate the knowledge that we learn about Shwachman-Diamond syndrome. And I think the major advances in our understanding have happened over the last maybe 4 years with respect to how changes in the blood cells of patients with Shwachman-Diamond syndrome can lead to more worrisome blood complications like things like myelodysplastic syndrome and acute myeloid leukemia. And so, as a blood doctor, that is something that I'm really, spend the bulk of my time thinking about. And in my patients with Shwachman-Diamond syndrome that I see on the adult side at Dana-Farber, one of the things I'll share with you today is how we try to utilize this new understanding of blood changes and what they mean for patients, and how we can apply that knowledge to develop a customized monitoring plan. And I know already I've heard several questions from the audience in attendance and others that have been interested in this topic, having questions about what do we make of and then how do we interpret the changes when we get these reports from our physicians. And so I wanted to give you a framework to understand that. So I'll share my slides. I'll be going over a few things. So hopefully you can see this okay. Um, so I don't have any relevant, disclosures for this presentation. And what I'd like to talk to you about is, in brief terms, understanding and describing the really spectrum of clinical phenotypes that we see on the adult side. I know many of you are well familiar with how patients can present very early in life with Shwachman-Diamond syndrome, but some of the things that we're seeing when we take a different approach to screening and diagnosing patients at Dana-Farber, we're actually realizing that the spectrum is quite broad. And I think that's something I wanted to share with you today. I think one of the key things that would be relevant for this group is to really describe and kind of dive into more detail the biology and the clinical outcomes of our patients that unfortunately do develop MDS and acute myeloid leukemia. And then I did want to spend even more time talking about how we approach the blood monitoring for patients with Shwachman-Diamond syndrome. And so I lead our adult program, as I mentioned, at Dana-Farber. This is something that I began in 2021, and it was really in large part a collaboration with pediatric experts across the street in Boston at Boston Children's Hospital, principally Dr. Akiko Shimamura, who's really been a fantastic mentor and advocate for how we've developed this program. I'll also highlight my mentor, Dr. Coleman Lindsley, who's been really instrumental and again, helping us to understand how the changes that develop in the blood cells of patients with Shwachman-Diamond syndrome can increase one's risk of developing those complications that we'll talk about. But we also have a close partnership with colleagues at the Brigham and Women's Hospital. And so, as many of you know, the patients that we serve with Shwachman-Diamond syndrome have multiple different needs, not just blood, but nutritional needs, neurology, hepatology, endocrinology. And so we need experts in those particular disciplines as well to really help us comprehensively care for our patients. And what I'm showing you on the right is, a growing, cohort of patients that we've identified and treat in our program. And this includes people that are diagnosed as children on the pediatric side and eventually grow to need adult care. And so that is something that we've been able to do in our program, is to transition patients from the pediatric side to our adult clinic. But as I was alluding to, one of the things that we've been able to do through a more systematic screening approach that we've implemented over the last 6 years is we've actually been able to detect a fair number of adult new diagnoses with Shwachman-Diamond syndrome. And I think this has been really helpful to be able to systematically identify everyone that we can that has this genetic risk factor. We also partner closely with our colleagues in the bone marrow transplant group at Dana-Farber, and we have a growing experience about how best to approach stem cell transplants for our patients with Schwachman. And so I wanted to give a little bit of background about what we know about the blood in particular. I think there's a lot that we could talk about and fill the time with in terms of all the various manifestations and aspects of Shwachman-Diamond syndrome, but I did want to focus on the blood for this conversation. And so I think some of the best data that we have, and I think it's really important. I should emphasize that I think when we make decisions and when we make recommendations for our patients at every level, we should really strive to do that based on data and observations that are curated and robustly analyzed. And so, to that end, this is a study that was published through data obtained through the SDS registry by Dr. Cass Myers and Dr. Kiko Shimamura and others. And what they looked at was over the age spectrum. So as individuals get progressively older with Shwachman-Diamond syndrome, what is actually happening with their blood counts? And this is the best data to date that we have to really answer that question. And so what I'm showing you here is the characteristics of the patients. There was 153. It's quite a large study given the rarity of this condition. And we see that it's represented at least a quarter of individuals are over the age of 18 and are adults. And one of the things that we will talk about, and I understand is anxiety provoking and worrisome, but the causes of death for patients with Shwachman-Diamond syndrome, unfortunately, a lot of that is due to these blood complications. And so I think it really emphasizes the need that we have as a community and as doctors to really understand the blood system as best we can to help our patients. And so what I'm showing you here on the graphs are the changes in the blood count parameters that we look for as doctors. So the first is looking at the white blood cell, in particular the neutrophil count. And we can see that it largely stays pretty stable over the course of or over the age spectrum, but there is a slight increase in the absolute neutrophil count. And this corresponds to anecdotally what we often see in our adult patients is that sometimes their needs for GCSF, for instance, their growth factor needs may decrease over time. They may no longer need GCSF. And I highlight this because it's possible for community providers that have less familiarity with Schwachman to interpret that change in blood counts as a positive thing, perhaps indicating that stricter monitoring of blood counts maybe isn't necessary. And I want to caution against that, and we'll talk about that. What I'm also showing you here is the trend in hemoglobin, which is largely the red blood cells, which is largely pretty constant for the most part across the age spectrum. And what we also do see is that the platelet count, the cells that help the blood to clot and prevent bleeding, that tends to go down a little bit over the age spectrum. And in the bone marrow, when we're doing these examinations, one of the things that we can see is that the bone marrow cellularity is often quite lower than expected for one's age in Shwachman-Diamond syndrome. And so what I'm showing you here is a plot of each dot represents a patient, and this is the percentage of the bone marrow that is made up of healthy blood-forming cells and the age of the individual. And what you can see here, this dotted line here, this yellow dotted line, this is what we would expect for someone at the age of 10, the age of 20, the age of 30, for the relative proportion of healthy blood forming cells. And what you can see in general is that most people with Shwachman-Diamond syndrome have less cellularity in their bone marrow than expected for age. And that's a feature, I would say, not necessarily a disease or a problem unto itself. But what it does represent is that this is why we consider Shwachman-Diamond syndrome as a kind of bone marrow failure condition, because the bone marrow as an organ system is trying to produce enough healthy blood forming cells as it can, but often not achieving that. And so, as I was mentioning at the outset, one of the biggest revelations over the last several years in terms of how best to identify individuals with Shwachman-Diamond syndrome that are at risk for bad blood outcomes is really utilizing next generation sequencing. And so this is something that we do often at Dana-Farber and many other, academic centers, is that when we do a bone marrow biopsy or even more frequently now in the peripheral blood, we can just do a blood draw. We can actually look in a very sophisticated, focused way for the types of mutations or changes in the DNA of the blood cells in that sample to help us identify individuals that might have a risk factor for developing into a blood cancer specifically. And so this is work that was led by Alyssa Kennedy, who's now at St. Jude, Coleman Lindsley, and Akiko Shimomura as well. And Cass Myers was also instrumental in this study. And what this is showing is that each column right here, each column is an individual patient. And these are individuals that have a diagnosis of acute myeloid leukemia, myelodysplastic syndrome, and then a larger subset of individuals that actually don't have any of those diagnoses. And the major finding from this analysis was that these TP53 mutations highlighted in red are actually very, very common. We had some evidence of this in the years before this study. We kind of knew this to some degree, but this was really the first clearest sense and clearest look at this phenomenon. And what we were able to learn from this is that when we sequence the blood very deeply, this is very, very common. And I would say that the majority of patients, as you can see on this graph here in the middle, is that this purple is representing the proportion of individuals of a given age group that have detectable mutations, so-called clonal hematopoiesis, so CH here. And what you can see is that as folks with Shwachman-Diamond syndrome approach and enter adulthood, basically everyone has some degree of acquired mutations in their blood cells. Most of these are P53, but we also have other gene mutations as well, such as EIF6 that's highlighted in blue. But I just wanted to emphasize for this group that having blood mutations is effectively everybody as they enter adulthood. And so that really behooves us to know which of those mutations are worrisome, which of those mutations maybe actually don't confer an increased risk, and how can we kind of monitor this over time. Okay. And so the major features that we've identified when we actually took these observations and really brought them to the lab and said, well, if we study how these mutations impact how cells that have them function, we can maybe learn a little bit more. And so this is a summary kind of schematic. It's a little complicated, so I'll just walk you through what this is actually telling us. And so this is looking at a relationship between a baseline, a degree of kind of fitness, and how robust is a given cell in the body at doing its job. And in this case, we're thinking about one of the blood stem cells, the stem cells that we all have in our bone marrow that are the baby white blood cells that eventually give rise to all of the mature blood cells that circulate and that we measure when we draw blood from our patients. And what this is showing is that in individuals that have the lack of this SBDS protein that really defines Shwachman-Diamond syndrome, they can improve the fitness of those cells by one of two major ways. We've known now for some time that we can mutate EIF6, which is an important, cofactor for this biological pathway. And individuals that have mutations in this particular gene, those cells actually don't have an increased risk of developing into leukemia as best we know at this time. But the major thing, and I think the topic of the day for this group is really understanding P53. And so the other way in which cells can address and try to improve the function of those cells is to lose one and then potentially two copies of this gene called TP53. And I want to highlight a little bit more clarity about this. So P53, we all have two copies. In every one of our cells, we all have two copies of P53, and it's a very, very important gene. It's one of the genes that protects the most from us getting cancers, not just blood cancers, but all types of cancers. And what we've identified is that in cells that have a lack of the Shwachman-Diamond, protein, those cells will often lose a copy of that P53 gene to allow those cells to work a little bit better, despite the fact that they can't make the ribosome the way that they should. And having a single P53 mutation like this is something we definitely want to know about and monitor as doctors. But the major thing that really concerns us is that when those cells that have a single P53 mutation develop another P53 mutation in the other copy in that cell. And it's that context in which patients will develop over time into things like MDS or things like leukemia. And what we've known now for many years is that individuals that develop this MDS or leukemia from these types of P53 mutations, unfortunately, don't do very well with our traditional therapies or even stem cell transplant. And this has been a game changer. It really has been a game changer for us to recognize this because what it affords is now an opportunity to really identify people well before they actually develop MDS and leukemia to try to improve the outcomes that we can achieve with stem cell transplant and potentially other therapies that are being developed now that just aren't ready for the clinic. And so this is the major kind of paradigm that I just wanted to highlight, and we can talk more about this as we go along. So let me give you a little bit more data to think about. So these are data from our Dana-Farber cohort. And what I'm showing you here is just how common it is that we see P53 mutations. It's very common. And so this is looking at the size of the P53 mutation. So 100% would be represented by this one. And this would correspond to a 1%. And this is 10%. And you can see that across individuals of increasing age, we see more abundant and larger
Yeah.
P53 mutations.
Oh,
And this is consistent with what we've seen as well in the published paper that first really kind of looked at this. And as you can see here, those that have a diagnosis of MDS or AML, the size of the mutations are often even larger. And so what we're able to do now is in our patients that have low blood counts or bone marrow failure, we can begin to detect those that have P53 mutations, and it allows us to establish a baseline that we can use to monitor those changes over time and hopefully identify those that are most likely to benefit from early consideration of stem cell transplant. And I mentioned before, and these are data that can be challenging to engage and to think about, but I think really important for us to just be aware of and cognizant of. And so these are the data for patients with Shwachman-Diamond syndrome that unfortunately did develop myelodysplastic syndrome and acute myeloid leukemia.
mm,
And many of these patients were approaching adulthood. The patients that I see that have had this were in their 30s and 40s even when they developed MDS. And the point of this slide is simply to make one single point, which is that if we wait to do something like a stem cell transplant for our patients that have clear-cut, obvious signs in the bone marrow of myelodysplastic syndrome or leukemia, we do a very poor job of helping those patients, even with stem cell transplant. And I think that is the take home that I would want you to kind of to leave with this slide is that the outcomes, if we wait too long, are just very poor. And so this is what has changed the approach that we have now. And so I wanted to walk you through this slide because this is a schematic that really highlights how we're thinking about this with this new information in mind. And so this is something that I look at and kind of draw out to the best of my ability. I'm not a good artist, but I draw this out for my patients. And really, it's to make the point that all of us throughout our lives fall somewhere on this continuum, from on the left, normal, and it's a little bit hard to define what that is, but suffice it to say, people that have no blood mutations, they have normal blood counts within the normal range. So that I would call that normal. And then many of our patients with Shwachman-Diamond syndrome have bone marrow failure to some degree and will have low blood counts. And then as we kind of go through this spectrum, we see that individuals will eventually, or not, I should say that differently. Some people will develop blood mutations, and we think about that in a different context. And so that's why I colored it differently. And then some patients, not all, but some patients will unfortunately develop into MDS and leukemia. And what I'm showing you here is that across this spectrum, we can at least conceptually think about an increasing risk over time of developing this blood cancer. And so this is what's informing how we approach the monitoring. And so what I'm showing you here is kind of our current approach, recognizing that, as I mentioned before, we have to be guided by the data. And so as new data comes out and tells us that maybe our approach is right in some ways, but less optimal in others, we have to be willing to adjust. And so I actually hope that what we're doing in the next several years will modify this slide because I think that'll mean that we learn more. But what I can tell you is that what we're doing now is that for folks that have a confirmed diagnosis of Shwachman-Diamond syndrome, we are still doing and recommending, annual examinations of the bone marrow. And this includes a biopsy of the core of the bone marrow as well as an aspirate. And I should have even bolded this, but next generation sequencing, I can't emphasize it enough, just how powerful and useful a tool it is for us to really understand because maybe this isn't intuitive or obvious, but when we think about as what we've done historically for patients is that we have a pathologist take a look at the bone marrow and we ask them to use their vision and their knowledge to understand are these changes in the blood cells concerning for things like myelodysplastic syndrome. I think what we're realizing is that we have a much better tool in the next generation sequencing. And so that's something that I think we're is going to be increasingly emphasized, and I think it should, as we realize that it's often the molecular changes, those mutations that really kind of precede anything that we can see with our eyes. And I think that's something that I think is really important to think about. So we do this annually for our patients that have more of a standard risk profile, if you will, recognizing that everyone with Schwachman has a greater risk than the average person of developing this, a far greater risk. And then there's individuals that as we go through their surveillance over years, eventually if we see changes in their blood cell counts and or mutations that cause us to have more of a need for closer monitoring, we sometimes do the bone marrow biopsies or evaluations of their blood in some other way more frequently. And that could mean anywhere between 3 to 6 months. It just depends on the clinical context and how concerned we may be and what the patient would like to do as well. I also highlighted here transplant evaluation and donor search. Um, my general approach, and I think many in our community are aligned in this, is that we think about early conversation and early considerations of this transplant question. This is because it can take time. It can take time to identify the best possible donor for a patient. It can take time to ensure that other medical issues that a patient may be facing are adequately addressed before thinking about a stem cell transplant. But I put this here on the early side because what I have seen work best for patients and families is when that conversation and planning starts proactively on the earlier side. It causes less anxiety and frustration and fear as people are getting closer to actually needing to go to transplant. And so I just wanted to highlight that. So this is the framework that I've been using, and I think we certainly will continue to adapt this as we learn more. We did publish this review several years ago now, and I still think this really holds true in terms of specific recommendations for providers, for physicians that are really trying to do their best and monitoring patients. And what we were able to kind of distill here are several what we call high risk features, things that would cause us as doctors to really think more carefully about a patient in a given context. And I'm just listing these here. This includes when we look at patients that they may have fairly normal or stable blood counts, and those start to change over time. When the bone marrow cellularity starts to be a little bit more increased as opposed to decreased, those are changes that we would want to think carefully about. And again, I think I'll highlight too that the P53 aspect of this, I think, is a central one. And so what we have realized over time is that certainly large P53 mutations are something that we would really cause us to really want to counsel patients and families and begin to kind of think about potential next steps, including transplant. Now, one of the challenges is how do we define large? What does it mean to be a large P53 mutation? And I can tell you this has been a source of confusion and lack of clarity in the field because in our typical MDS and AML patients, the size of some of these P53 mutations is considered small. When we think about it in the context of Shwachman-Diamond syndrome, we have a different kind of measuring stick, if you will. And so the kind of traditionally thought to be smaller mutations are ones that we actually really think carefully about. Again, because we know that we have a window of time in order to really try to optimize treatment and outcomes for our patients. So we can talk about more of that in the discussion. And I think maybe what I'll do, I have a few more slides that we can go through if helpful, but I really get a sense that it would be maybe useful to spend some more time just discussing specific questions and trying to clarify anything that I shared with you so far. So maybe I'll pause there and just kind of open it up for any questions or comments.
So Mary, we have, you there? We do have some questions on the chat.
Okay, let me take a look at those.
All right.
Would you like me just to go in order?
Yeah, that's fine.
Okay, so I have, let's see.
What
Uh,
age are you starting patients in your clinic?
That's the bottom. You're at the bottom.
Yep.
You want me to read the first one?
I could go up.
So when performing a bone marrow biopsy and performing fish studies in cytogenetics, should the report indicate that they specifically have checked for TP53?
that's a great question. And so I'll start by saying there's different types of studies that we order on the bone marrow biopsy. So fish and and traditional karyotype, those are both trying to assess fairly large changes in the DNA, so gains and losses of specific parts of the chromosomes, and that is a very important aspect. The types of changes in P53 that we are talking about principally are those that can only be detected in a few different ways. The best way by far is something called next generation sequencing or NGS. And there's many different types of panels of different genes. And so the one that we use at Dana-Farber covers about 80 plus 90, almost 90 genes. And we use that for all of our patients. And so we send that in addition to those things like cytogenetics and FISH and the traditional pathology assessment of the bone marrow. And what I've seen most often is that providers often don't do that. So, for instance, if they have a patient that has fairly normal blood counts, and if they've had traditionally marrow biopsies that are reassuringly kind of stable and kind of at their baseline, I have seen that that aspect, the next generation sequencing, isn't always included. And I think that's, in my opinion, I think it's a missed opportunity to really understand in a given moment, where a patient is on that spectrum that I talked about. I think one of the challenges has been making sure that one, providers know to order it, know how to order it. Um, the other is the insurance coverage and making sure that just because we have a test that we can do, it's important to recognize that we don't want patients and families to pay exceptionally high costs for some of these tests. And so that's something that's an ongoing battle that we're fighting as well to try to demonstrate with data that this is really an important aspect. And so at Dana-Farber, we're very fortunate. We can send that test pretty regularly. But I recognize that that's not always the case. And so what I would say for those that are interested in this and wanting to talk to their doctors about this, my advice would be to have them either contact the registry because we do have a molecular tumor board where uh, providers can ask us to opine on specific, bone marrow biopsies for patients, and including helping to interpret some of the next generation sequencing results. Because as I was mentioning, not all providers are equally facile and able to kind of put all the pieces together in terms of the molecular data. And so that's a service that we've offered through the registry to really kind of be another voice in the conversation about how to interpret that. I hope that answers your question.
Yeah.
Next question. NGS on blood versus marrow. Is it accessible to patients or still considered research?
Great question. And so many of the next generation sequencing tests can be sent on peripheral blood or bone marrow. And so those are clinical tests that are available now. And so that can be done. I think the challenge is understanding differences or lack thereof between samples if measured by a blood or a bone marrow. So let me clarify that. So if you have a patient that has traditionally had bone marrow biopsies and you have a mutation that you've identified in the years past, and now you measure that mutation in the blood as opposed to the bone marrow, there's a chance because the types of cells that are in those samples are slightly different that the number that you get in terms of the size of that mutation may change. And so Dr. Shimamura and others at Boston Children's are really focused on this question because, again, we really need to have robust data to answer that question. And so there's an active, big effort actually to understand, can we reliably measure the size of these blood mutations using peripheral blood as opposed to bone marrow? I can tell you as a doctor that orders bone marrow biopsies, I would love to be able to just measure this in blood as a surrogate. But I think until we have the data to really say that's definitely a feasible approach, that's why currently we're still thinking about the bone marrow biopsies. But I will say, what we have done and will certainly continue to do is for reasons that vary. There may be individuals that can't undergo a bone marrow biopsy easily for many reasons. And I would say that using the blood in that sense is much better than nothing. So I would always favor measuring next generation sequencing in either blood or bone marrow. But my preference until the data tells us otherwise is to really focus on comparing things in the bone marrow. But again, I think next generation sequencing overall is a very useful tool.
Okay. Next question. Have you seen any patients with autosomal recessive C258 plus T2 slash C P question mark heterozoic pathogenic carrier with severe neutropenia or other symptoms related to SDS?
That's a great question, and that is getting at the types of genotypes, the types of configurations of SBDS changes, and the symptoms that can arise. And so, um, what I can tell you is that individuals that have been thoroughly assessed for the SBDS gene and only have a single copy of this particular change, we think of them as carriers. And to my knowledge, there really has not been any data yet to link changes in blood counts or any other clinical features with individuals that truly have a single copy. The big caveat that I would add to that, though, is that because the SBDS gene is tricky to sequence and tricky to interpret all of the changes that might arise in that gene, it is possible for individuals to have a single copy of that gene detected, as mentioned in the chat, but there may be still another copy or another variant on the other copy of that gene that could produce Shwachman-Diamond syndrome or something like that. And so the challenge there is for the doctors who are helping to work up those cases is to really assess what is the likelihood of something like Shwachman-Diamond syndrome in a patient that has just this single copy, and because that will often trigger us to dig deeper and say, is there something else? Is there a different change that might be difficult to detect by our standard approaches of sequencing that might actually give us the answer? And so I hope that's a tricky one, but it's a good question. I hope that clarifies it to some degree.
Okay. Next question. We are low risk right now, and a few years ago, there was a donor search which indicated there were options. How often should the donor search be done? Every 5 or 10 years?
That's a great question. That's a great question. I would say that there's no single right or wrong answer to that question. Um, I think about this in terms of in a given time frame, how what is my assessment of the patient's likelihood of needing a stem cell transplant in the next couple of years? And so, in that sense, the donor options do change. They do change over time. So what we typically do is an initial donor search of the unrelated registry, for instance, and that's simply using the HLA typing, so the immune proteins on the surface of the cell, to find someone that would be a suitable match, either a full match or almost a full match. And that is just to tell us the first question, which is, are there people out there that could be a good match? And then the next series would be, are those individuals still willing and able and capable of donating? And so we usually don't take that step until we feel that the patient is really kind of ready to take that step and go to transplant. And so it's always possible that the true number of donors that would be good matches will certainly fluctuate and vary based on the circumstances. And so I don't have a specific answer to that question in terms of we do it every X number of years. I think it really depends on in a given year, what do we think the likelihood is that someone would need a transplant in the next, 1 to 2 years, I would say.
Perfect. Next question. At what age are you starting patients at your clinic? And is it at age 18?
Yes. So right now it's age 18 and above. I don't have the ability to care for patients under the age of 18, but we do partner closely with Boston Children's Hospital as well. And so traditionally, actually, people have been coming to me in their early 20s usually. So oftentimes the transitions are not, right at the age of 18. But yeah, we certainly have the capacity to care for patients 18 and up.
Okay. Uh, Next question. What role does VAF play in evaluating new TP53 variations? My daughter has one EFL1 mutation noted, several VUS, and on most recent marrow, NGS at 2-year intervals, a new TP53 variation at 3.2% VAF.
Thank you for that question. So this is what you're describing as a situation that we see often. And so there's several things I want to say about this. One is that in individuals with Shwachman-Diamond syndrome, as I mentioned, the presence of acquired p53 mutations is very common, very common. And if we sequence deeply enough, it's effectively everybody. And so, with that being said, you have to recognize that many of the changes at low level that we do identify or could identify with deeper sequencing in the gene TP53, many of them do stay at a very low level and stable for as best we know, many, many years. And so I would underscore that the majority of the P53 mutations and really everyone, but including patients with Shwachman-Diamond syndrome, don't actually develop those additional changes and lead to blood cancer. But and so how can we use that information? So one is to know how recently did a mutation become detectable. And so this is where the monitoring can be really helpful because if we do an initial bone marrow biopsy on a patient in their 30s and we see that a p53 mutation is at 10%, that's in my world that's very large. And but we don't know, did that happen in the last 6 months? Did it happen 2 years ago? Was it the same level 5 years ago? And so having those serial time points like that can be really helpful to understand the trajectory of these changes. Um, Let me just read, but the VAF, so the question specifically was about the VAF. So the VAF is simply an estimate, a measurement of the number of DNA molecules in that sample that have that particular change. And so we use that to surmise the proportion of cells that have that mutation. In other words, the size of that clone, if you will, is the term that we often use. And so in individuals that have a mutation, around 3%, the simplest interpretation of that is that change is probably present in approximately 6% of the cells in that sample. If it was a bone marrow, it'd be 6% of the cells in that bone marrow. If it was in the peripheral blood, it would be 6% of those cells. And that's where, again, measuring from marrow to marrow or blood to blood is probably the best way as of right now to really know the relative changes in that VAF metric. Um, does that answer your question, Jenny?
Yeah, I think so. I guess I was just having a hard time telling, we didn't have it 2 years ago, and then when it
Mhm.
pops up, it's at 3.2. And I couldn't tell, if that was significant or if that was a measurement that really mattered, or what was simply more important was that the variant itself had shown up at all.
Yeah, I agree, and I think we have patients, for instance, that have variants in p53 at close to that level, and they can be stable if we tend to do annual bone marrow, so they can be stable for I haven't been doing it that long, mind you, but 2, 3, 4 years can be quite stable. I will say though that that this is exactly the type of kind of clinical context where we can be really useful as a molecular tumor board. And so one of the things that I think I really encourage everyone to kind of utilize this is to just have the doctor who's ordering the test and monitoring the patient contact us to reach out to the registry. We can set up a Zoom call. It's often myself, Dr. Shimamura, and Dr. Myers as well. And we'll go over this data in detail in terms of the size of the mutation, the timing of the last bone marrow, other features, and really try to put the pieces together. Because I think it's we even us, like, we need, advice from others as well to help us to make the best decisions. And certainly the docs that are doing their best but don't have the depth of expertise in SDS, I think really should lean on people that do. And so we can certainly help to be that resource for them.
Thank you.
Perfect. Next question. My 11-year-old son had a bone marrow transplant 3 years ago after finding a TP53 mutation. Should I continue with bone marrow biopsies every year as a checkup?
That's a great question too. So a few thoughts there. When we do a stem cell transplant for anybody that has a diagnosis of a blood cancer, things like myelodysplastic syndrome or leukemia, there's a worry always with people that actually have a blood cancer that even with a stem cell transplant, some of those cells could still come back and grow. And so in that context, we often will do a bone marrow biopsy in the first, 100 days, first year or so after a stem cell transplant to really assess that question. It's actually a very different situation when patients are transplanted, not because they have a blood cancer, but because they have changes that make us worry about a blood cancer in the future. And the good news is that when we do a transplant in that situation, where people are kind of, again, marching along that continuum that I showed, but really don't have a blood cancer diagnosis, the chances of those cells coming back are very, very low. I never say 0%, but it's very, very low and a much better situation in terms of risk compared to if we try to do a transplant in someone that has MDS or leukemia. And so to that point, I would say if someone were to receive a transplant for a more of a concerning high risk feature situation like we talked about, I don't think doing annual bone marrow biopsies indefinitely would be necessarily. I would tend to want to check one, as I mentioned, in that first year, that 100 days to first year after transplant to make sure that we don't see any evidence of those mutations. But after that, I would really guide it based on the blood counts and not necessarily do ongoing bone marrow biopsies. But others may have a slightly different practice.
Okay. Last question. Please explain the risk of solid tumors in STS. For background, there have been several cases of breast cancer.
That's a great question as well. A few thoughts there. So one is that the cancer risk that clearly has been best elucidated and shown in Schwachman is what we've been talking about, which is the blood cancer risk, MDS and AML. But we are learning more. And so one of the newer revelations over the last couple of years, and was enabled by the data collected through the registry, is that there are cases, certainly cases of individuals with Schwachman developing lymphomas and other types of blood cancers that aren't the typical variety that we have been talking about. And so that begs the question, really two kind of lines of thought. One is that are there any other potential cancer risks associated with Shwachman-Diamond syndrome? I think the short answer is we don't know. We don't know the answer, but I think it's a question that is answerable with more data. And so as of right now, I am not recommending, patients to undergo additional cancer screening. But again, we have to be, guided by the data. And then the other thing I will say as well is that certain types of cancers will occur in like independent of the germline genetic background. And so patients with Schwachman, patients with other types of genetic disorders have a chance of developing other cancers as well that are fairly common. So it doesn't necessarily mean that if a cancer does arise in a patient with a given known genetic background, that it was caused by that genetic background. And I actually think that's probably the more likely scenario in most of these cases. But I wanted to highlight the first to say that, we don't know everything, and I think we still need to keep an open mind. But that would be my approach right now, to think that some of these cancers may be unrelated to the Shwachman-Diamond syndrome specifically.
Could I interject? I have a quick
Please.
question. However, we also see depletion or mutations of TP53, which is well known to be the guardian of the genome. And therefore, if we do not have a robust TP53 response, will we be seeing more solid tumors? As we age, as we have older and older patients, and the normal progression in older patients would be more mutations in other cell, in the cells in general, in the DNA in general, would we be having to perform greater and greater surveillance for solid tumors?
It's a great question. I think it's a great. The logic is perfectly sound, and so I totally understand that. And I think it is a possibility. But I would say that in order to change the way that we would monitor, I think I would want to. We would need to have the clinical observations kind of guide us there. But I totally agree, and this has actually been shown, for instance, in a totally different genetic context of Li-Fraumeni syndrome, where the p53 mutations are in the germline, but those individuals also have a much higher risk of developing other types of cancers, solid tumor cancers, and it often is because of this p53 pathway of kind of losing that second copy. And so I agree with you in concept that it is certainly possible, but I think what we've seen in the natural history of Shwachman-Diamond syndrome so far is that the blood cancer risk is really kind of what is most prominent. But I agree if we can, gosh, I actually hope for this day where if we could really deal effectively with the blood cancer risk, it would give us an opportunity to study these questions more robustly, actually.
All right. Perfect. Does anybody else have any questions last minute? No? Okay. If anybody finds that they have a question, you can certainly email me and I can get them to Dr. Chris. And otherwise, I would like to wait one more.
Yeah, I see just one more question came in.
Yeah.
Continue to do annual bone marrow biopsies after finding TP53. She just turned 18. TP53 is now at 3.5, and it was found a year ago.
An important question. This is another one where I really do think that the molecular tumor board through the registry would be best suited to kind of dive into cases in detail. I can only say how we have approached similar situations. Okay. And I would say that when I start to see some of the mutations in P53 be persistently detected at a VAF that's in this kind of range, those are situations where I think about, do I want to look more frequently in the bone marrow? Is the annual bone marrow, should that still be the interval, or should we think about doing it more frequently? And I don't know the right answer in this particular case because I don't have all of the information, but that would be something where I just wanted to highlight how the thinking kind of can change as you get more data. And so when I see that, that's a situation where I ask myself as the doctor, should I wait a year or should I do it more frequently? And I don't know the right answer there, but I just wanted to highlight that's how I think about that type of information. And we're happy to dive into that in more detail in the molecular tumor board if the physician is able and willing to have that conversation with us.
Okay. Two more questions came in. At what point do we feel bone marrow transplant is contraindicated due to age?
Great question. That's also a moving target. And so I remember when I was training, it was rare to do a stem cell transplant for patients over the age of 60. And now we're talking about doing this. And again, this is outside of just the Schwachman context, but patients in their 80s, and we're thinking about it. We're thinking about it. I would say right now, most of our patients are transplanted in their 50s to 60s, some into their early 70s. And so what is that based on? That's based on learned experience about how to do transplant better. Understanding how do we prevent things like graft versus host disease? How do we select the best candidates that would optimally benefit from transplant. But I'll say in Schwachman, it is different, right? It is different because patients with Schwachman have a higher predisposition to some of the toxicities of transplant as well. And the data from the registry is telling us that on the adult side, we have room for improvement. We definitely have room for improvement in terms of reducing the toxicity of our transplants. And that's what we're seeing in patients in their 30s and up is that that risk of toxicity is there. And so I think what I take away from that is that I don't see age as a contraindication to transplant, but I do see it as an added risk factor for transplant. And so thinking about the totality of the risk factors. So we talk about the risk factors in the blood that we identify, but I think about patient-specific risk factors. You know, how old are they? Do they have other medical issues that would make a transplant more risky? And perhaps that I think that should actually factor into the decision making ultimately of yes and no. Does someone get recommended to transplant? And if so, when? And I think and this is a very complicated matrix of variables that needs to be considered. And so I hope that, so the specific question about age, I would say that for our Schwachman community, I think there's no age cutoff that I would feel strongly about. But it does increase the risk of complications as patients get older for sure.
Okay, perfect. And do we have data on DNA JC21 VUS?
So I'm assuming, and Ramona, feel free to clarify your question a bit. I'm assuming, do you mean, actually, Ramona, it would be great to understand a little bit more about what kind of information you're looking for there.
Ramona, you can unmute.
Because I could surmise maybe the question might be, oh, hi, Ramona, I see you.
Yes, I was wondering the DNA JC21 on the NGS panel for genetic diagnosis.
So we do see VUSs or variants of uncertain significance in DNA JC21, and so we often need to figure out is this telling us something about the patient, or is this a variant that really doesn't impact clinical management? And so I haven't seen many cases, to be honest with you. I think I've seen one patient that came in with a variant in that gene, but ultimately we identified that there was a different diagnosis and it wasn't Shwachman-Diamond syndrome. So I think that's another area where we still don't know as much as we'd like in terms of the other genotypes that have been kind of associated with the clinical, spectrum of Shwachman-Diamond syndrome and the risk of these blood complications. I think we're still most of the data by far is weighted towards those that have the SBDS mutations, but I think we need to develop more data to really understand how the other genotypes might fare in terms of their risk of blood complications.
Thank you.
Perfect. Is the Shwachman-Diamond registry? I can send you. Oh,
I replied to the question, so we're good.
thank you. All right. I think that's it. I appreciate you coming on today with us and, taking your time.
Reilly, did you have something you wanted to wrap up? I wasn't sure if you finished your.
Oh, I'll just say I really appreciate the opportunity. I recognize in my practice just how critical the need is for this understanding, and I can recognize I do recognize how scary some of this is to think about and to have sometimes the providers not not have the depth of understanding as you may like. And so what I would say is that our mission is to really communicate this growing information and knowledge. And so our doors are always open. Please do reach out to the registry. We're happy to work with your care team wherever they are in terms of putting together a monitoring plan. So you really don't have to feel as if you're alone in this. So we're happy to help.
Perfect. Well, thank you so much for joining us. And if I get any questions over the next couple of days, I'll definitely send them to you. And you go have a great day with your wife and enjoy New Hampshire.
All right. Thank you very much.
Thank you.
Thanks,
Bye, guys.
everybody.
Bye.
Thank you.
Thank you.
And for anybody who joined late, we will be recording it and we'll send out a link for that.
I gotta go. The dog's barking. How do I leave?